Hello, welcome everybody to the benefits of working in residential aged care facilities for GPs. There's a few people coming in, so we might just give it another minute or two. If you could keep your cameras on, because we'd like this session to be interactive. So it'd be lovely if you keep your cameras on. All right, we've got 18 people.
Gordon?
Hello? And also, if you could keep yourselves on mute throughout the session. What we'll do is we'll have questions and answers at the end of the session. And if during the session, if you think of a question, if you could write it into the chat feature, you'll see a little icon that says chat on the bottom of your screen. If you just click that, write your question in and we can answer them at the end. So we'll just get started then. So if we could have the next slide, please, Jag. Before I do the acknowledgement of country, I'd just like to remind you that the session will be sent to you by email after the webinar. And this will include any resources as well that we talk about today. So before we start, then I'd like to do an acknowledgement of country. So the North Western Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon Wurrung people, and the Wathaurong people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Next slide. Thanks, Jag. So yeah, just to reiterate some of the housekeeping. So we're on a Zoom meeting platform today. So if you could keep your microphones on mute, please, throughout the presentation. Please ask questions via the chat box. As I said before, the session is being recorded. And importantly, if you can make sure that you join the session using the name that you registered with, so that we can mark off your attendance for your CPD points. If we haven't got your proper name, we can't confirm your attendance. Next slide, please, Jag. So if you need to change your name in Zoom, you click on participants. Now, if you're in the app, just click on your name and you'll be able to change it. If you're on the desktop Zoom, just hover over your name and click the three dots. If you're on the Mac, and this will enable you to then change your name. If you're on a Mac, hover over your name and then click more. And then click on rename, enter the name you registered with and click done, change or rename according to which platform you're on. If you have any problems with that, just put a message in the chat to myself. So I'd like to introduce to you then our speaker tonight. So our speaker tonight then is Dr. Jag Dhaliwal. Jag is a Melbourne-based GP with a special interest in aged care. He's an honorary senior lecturer at Monash Medical School, focusing on communication skills, and also is a research translation fellow at trophy.org.au, leading research on artificial intelligence transcription tools in aged care. He's also the medical director at Alternaleaf and a medical advisor to Hot Doc. With over 20 years of experience as a GP in England, Dr. Dhaliwal has held senior academic and advisory roles, including Deputy Director at Keele Medical School, Associate Professor at the University of Warwick, and Consultant to global and SME healthcare technology companies. He has also lectured internationally on healthcare leadership, aging, complexity and innovation, and also has previously chaired the North West Melbourne Primary Health Network's Older Adults Expert Advisory Group. So over to you, Jag.
Thanks, Kath. Thanks for the very warm welcome and good evening, everyone. Delighted to be here to talk about working in residential aged care. Just before we get into that, though, to signpost colleagues to some resources which are really useful for this type of work. So particularly I'd like to talk about health pathways in residential aged care homes. So Pathways are written by GP clinical educators, and they have support from coalface GPs and also our non-GP specialist colleagues and other subject matter experts. So it's written by people that are on the ground with experts, meant for us in practical situations and on the ground. So an incredibly useful resource. And as we're going to talk about, there's an incredibly diverse range of work that we do in aged care. So trying to keep that all in your brain is challenging. And I think, why do that when you've got a resource like Health Pathways? So any of these issues or challenges that do arise in aged care, you can find something that will help you that's evidence-based right there in Health Pathways. So that's the benefit. And just specifically to talk about the dementia directory. So these slides will be shared, as Kath mentioned, and you'll have the opportunity to listen to this presentation. But essentially, the dementia directory provides a list of local services to support people living with dementia within the Greater Melbourne area, and also complements existing directories from My Aged Care and NDIS. And their information sheets, again, to empower patients and their families. So a really useful resource to be aware of. Health pathways to flag when you search for information. Of course, there's intrinsic value, and the nice thing is it does count towards your CPD as a GP. So there is a link there that shows you how you do that, and you can self-record the CPD as you do it. And how do you access health pathways? Well, I mean, we've got to count the benefits, the silver linings of COVID, and one of the silver linings is we all know how to use QR codes now. So, yeah, there's a QR code there if you'd like to maybe take a photograph, or of course you're going to get the presentation as well, and you can access it through that way. Or if you want to go down the more traditional route, you can sign in or register. So that's how you access health pathways. So, why choose aged care or aged care medicine as a specialty area as a specialist GP? That's what I'd like to talk about today. And I'm guessing our audience is comprised of GP colleagues, and there may well be other clinical colleagues as well. I'm hoping there are. So nurse colleagues, allied health professionals. A lot of what I'm going to say applies to you as well. PCA colleagues as well. It all applies to you as well. But I'll talk from the GP lens for tonight. So my background, so I've got an academic background at Monash University. I'm interested in communication skills. Then the middle one is I work 99% of the time now in aged care as a GP, and then I also am interested in research as well, particularly AI and the use of AI in an aged care setting. So there's an academic background, a very practical background, and also an interest in where we are now, where the future might take us with the benefits and the opportunities technology may present them. So that's really where I'm coming from in this talk. I was born in London. I've tried and tried and tried. I can't lose this Pommy accent. I normally have to have a couple of glasses of wine, then I sound a bit more Australian. I immigrated to Australia about 10 years ago now, and initially worked in a bulk billing practice, and then switched to mixed billing practice, encouraged by peers to try aged care at that time. What I enjoyed working in the bulk billing practice because it was a good way of starting to understand our healthcare system in Australia. But I've always, as a doctor, known that I like the time to be able to spend with patients and their families. So it was good to be able to go to a practice where I could do that. And then it made sense then to be able to switch into aged care, because this is really where I found that that there's the opportunity to help not just the patient themselves, the resident themselves, but the family, because the family is typically desperately worried about mum or dad, wants to optimize their care, and that has negative impacts on the family's life. And conversely, when you can help, you help not just a person, you really do help a whole family as well. So that's why I'm really passionate about this. So I can say now that I'm really deeply satisfied and fulfilled with this role that I have in aged care because of those reasons. I feel I'm using the full spectrum of my skills as an experienced GP. So which skills are these? Well, we talk about the science here and the art of medicine, and my God, you have to use both. Let's start off with the art first of all. Um, so I enjoy communication skills. I teach communication skills, and I'm finding that it really means that I have to use the pinnacle of the skills I have to be able to communicate. So communication with someone who's got a cognitive impairment, of course, takes time and patience and trying different approaches. Communicating them with a healthcare team around that patient, and we've got the lovely PCA teams, the nurses, the allied health teams. There'll be the non-GP specialists, so geriatricians, of course, but it's not unusual to be talking to a cardiologist, maybe a respiratory specialist as well, so that I can play my role as the GP and the coordinator of care. And then, of course, we've got families who often are very stressed, and being able to take that into account, to honor that and to be able to listen to that, and then to be able to gradually work with them to get people to a better place. And then, particularly in Melbourne, lovely, wonderful, metropolitan, multicultural Melbourne. There are all the different languages and cultures that we take into account as well. So it's just a rich, rich picture in terms of using every ounce of skill I might have developed over my 30 years as a doctor to be able to communicate. And then there's the science, because older people, particularly in residential aged care, have a lot of complexity. This isn't the realm of just cardiovascular disease. There'll be cardiovascular disease plus respiratory. There might be a cognitive impairment. There's often a psychological element. So we're using all of those aspects of medicine that we learnt about in medical school, and then after that in our GP specialist training. So everything gets used, and then there's a knock-on effect also in terms of communicating with the family. So the science and the art of medicine get used to their fullest, I feel, in an aged care setting. So this is the typical history of a new patient that comes in. So Maisie typically has a lot going on. There is dementia, delirium, depression, high cholesterol. So obviously I've anonymized this, but this is an actual patient medical history. It's fairly typical of the sorts of things that we're thinking about. And I'm sure colleagues, as you look at that, your brain is whirring and you're starting to think about what might be going on. And that's part of the excitement here, starting to make sense of what's going on here. How do all these different elements what's the interplay between these different root cause conditions? And then we have the whole issue of tablet load. Each of these, often the older person concerned has seen a different non-GP specialist who's added their own pills and potions in, and that then means there's a whole fistful of tablets to take every morning. So we have a really critical role to play as the GP, being able to look at medicines and rationalizing medicines, and working very, very closely with our pharmacist colleagues. So the net effect of this is that you're kind of doing several things. So what I'm trying to illustrate here is, here's the central person, the resident, the patient, and it's about us as doctors, as GPs, specialized GPs, going back and doing the science. What's going on here medically, talking then to the wider healthcare team, comprised of everyone. I mean, the PCA staff often get missed. So the personal care assistants, just to explain the jargon. So personal care assistants, because they're showering, washing, seeing that person at the closest quarters, tend to be incredibly useful. Not sorry, useful is the wrong word. Incredibly knowledgeable first witness account holders. They'll tell you what's going on, what's really going on day to day for that older person. The older person who very often, due to a cognitive impairment, doesn't have their own words, but the PCA and other staff can. So our job then becomes to put all these pieces together and get a positive cycle going, so you can start to grow what's going to be your management plan for the person. That's the thing that's really exciting. I'd like to then, I talked about the role of the doctor and the art of medicine and our role in communication. So one aspect I find is really crucial to our role as the GP is the narrative, the story. So what am I getting at here? You might have two people who are going through exactly the same set of circumstances, but what can make one person feel better is the story that we tell. And often we as doctors and we as healthcare professionals have a really powerful part to play in telling that story. I mean, so for example, I mentioned I emigrated from the UK 10 years ago. I can tell you a tale of woe. 10 years ago, I was in the UK. I had, lots of academic posts and, life was going really well. I had my own practice. Then I moved to Australia and I don't own my own business now. I don't have as many academic posts as I do. I can't go to Europe all the time. I don't have all the fabulous networks I had in the UK. Are you feeling depressed yet? Because I am, and I could completely depress myself. And then the same reality is, hey, I had a great time in the UK, loved it, gained loads of experience. I emigrated 10 years ago, and how amazing. I never thought that I would be living in Melbourne, and I am. And I've got a great set of colleagues now. I've moved into new areas that I never thought I would before. I've built up new types of academic connections, and I'm doing work that's absolutely fabulous. And I'm so lucky with my life. Now, that the point of telling that story wasn't me going on some sort of ego trip. No, 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 I wasn't getting at that. It was about the stories we tell ourselves. And one, I was seriously starting to get depressed, and the other one, I'm actually pretty good. So we as doctors get to tell this story too. And so a typical narrative I will give to this person over here is listening first, really acknowledging the heartache that people are feeling. Often it's an adjustment disorder of having left a life behind and having come into aged care. So that can't be skimmed over. I mean, you can't just do a positive thinking thing with this person. You've got to really acknowledge it and allow space for them to feel that pain. And often the family is in pain as well because it's a different setup. So having done that and having really acknowledged, borne testimony, and there's something powerful that when a doctor listens to you, people really, because because we are accorded this position in society, it's really powerful. I'm joking here, and I know that. So I get called father for some really obscure reason, and I asked a priest colleague of mine. He says, "Yeah, I get called doctor," and we did laugh about it. And he said, "Yeah, that there is an interchange here. You can see why people do that because people want to be able to talk to you and say what's going on." So having acknowledged then my job is about talking about how we're going to use science. That previous slide, what have we got in place that we are thinking that we can do to help? But always it's about offering options to the person to say, look, these are the things we could be doing, smiling, and then starting to engage with them about, look, I know life is different. I know that's so painful. You know what though? Life could improve. I see other people here who are just the same as you, and life is getting better for them. And we could step by step making it better. So keeping that positive, upbeat type of approach, it really does make a big difference. And then also having that narrative and speaking to members of the aged care team. A good example would be from this past week. We've had a person, he's a lovely, very, very well-read, well-traveled gentleman who's got vascular dementia, and he's been having behaviors for the past couple of weeks. And the real light bulb moment was when we asked his family to go through a list of things that he's interested in talking about. My job as a GP was to trigger and say to the aged care staff, let's get a list, and we have, and the list is up now in the nurses station. So the nurses then have a hit list of things they go and talk to this gentleman who I'll call Henry, and it's transformative. So things like this around narrative, the art of medicine, thinking of these ideas, empowering our nursing and team colleagues to be able to do this is a key part of this role, the art of medicine. So stories to be constructed essentially is the bit that I'm getting at. So you have the science and then think about the narratives that we can share with our patients to be able to build up a picture of hope. Even dare I say it, somebody coming to the end of life. So that's often, a standard, the toughest conversation. And having a way of being able to express it, and I know the way that I do that is having accepted and acknowledged the pain of this. And then I use a phrase along the lines of, this is sad, and I feel it too. And you know what? It doesn't have to be depressing. It doesn't mean that we have to listen to sad music. Let's get on some of the tunes you really used to like listening to earlier on in your life, maybe. Or what are some of the smells and odors that you really like smelling, and any foods that you really like? Let's try and do this. And saying a few well-judged words like that, once you made that connection, can be transformative, and that gives me such deep, my colleagues and I who work in aged care, such deep job satisfaction, because you know that you made a positive difference to not just the person, but to the whole family. So GPs, vital role as storytellers. The narratives we tell can bring hope. And actually, they don't just help the person, it keeps my batteries charged. Hopefully my body language is coming through. I'm passionate about this because of those stories. And conversely, negative narratives just lead to hopelessness and depression. So I would say to you colleagues that if that's something that appeals to you, this is definitely a role to get involved with. It's a fulfilling path if you've got a very much a can-do attitude. Decided that we're gonna do the best we can, being realistic about age equally means that we do everything that's reversible, that can aid the quality of life, and equally accept the things that are, that we probably jointly have to accept are a part of the aging process. Adding quality of life, that each day is a day worth cherishing. You can do a lot in a day. You can live a lot of life in a day. So yeah, probably just going on. So what's the stories do you want to tell? And there was an interesting bit of research actually done by the University of Adelaide and Vanderbilt University in the US that said that in the English language there are only 5 archetypical stories we can tell. I won't go through them all, but you can tell a horror story. So you can spin the same facts to make it into a horror story. You can turn it into a mystery. You can make it a comedy. You can make it a romance. So think about the way you use your words. Narrative is really important, I think, in medicine anyway, but particularly in aged care. People look to us to do this and help them with that. And often it's the GP that helps to set that tone. Let's get into some practical points. So other reasons for picking aged care. Flexibility, that was a powerful one for me. So when we emigrated, I had 2 kids at school, a wife with a busy, a great career, traveling a lot. So one of us needed to have the flexibility to do school pickups, and you know what it's like. The schools, bless them, last minute will suddenly decide that we need to run round to the supermarket and pick up pens and crayons to make the thing that's due tomorrow. I think, oh gosh, all right. So the great thing with aged care is I could flex the days. So I have different days that I go to different aged care facilities. If something suddenly crops up and I need to curtail my time, it means that I can definitely go and see patients and deal with the urgent work, could then go and do whatever needed to be done with the family and either pop back later in the evening or sometimes just schedule to go in the following morning. So there's a great deal of flexibility that we have. That's, I think, a lot harder with standard booked appointments in practice. I did try and do aged care work on days when I was in practice. I found that stressful because I would sometimes have to wanted to take longer at the aged care facility, and then I was always conscious of the packed waiting room. So think about the flexibility. Also the stability. Demand for aged care services consistently high during the year. Um, Certainly in clinic, sometimes January would be a very flat month, and I would be, more or less twiddling my thumbs. I could keep busy doing other things. Whereas in aged care, there's always the demand. There's always work that needs to get done. I also really like the sociability of aged care. I do remember in my first year, I shared that I worked in a large corporate bulk billing practice, and it was a nice team, but I could go the whole day without seeing my colleagues. I would see plenty of patients, and of course, that's great. We get that human connection. But there's something different, isn't there, about chatting to your colleagues, being able to offload, uh, pick up some useful ideas. And aged care is incredibly collegiate because you're going to be meeting the whole of that healthcare team, the PCAs, the nurses, the allied health professionals, and learn a heck of a lot from them. I mean, so much I've picked up from the PCAs and the nurses, tips and tricks, and it's there for the asking. If only you ask and you show that humility in terms of value, the judgment and the perspective they have. I particularly like when I'm doing rounds with the nurse in charge. We do it as a joint thing, and I really like it because I'll say something like, I think we should maybe do this. Do you think we should suggest this to the patient? And sometimes the nurse, and often nurse will just take a sharp intake of breath. Are you sure about that, Jag? And I'm like, oh, you've got concerns. And then she'll say, well, how about this, and this? And then we'll have a chat, think about what would probably make sense. Then we'll talk to the resident and their family. But that is fun. That is collegiate. That is really being able to building the expertise you have. And similarly, it happens with the geriatrician. We'll swap ideas. Geriatrician will have some great ideas, and sometimes like, yeah, that's great, thank you. I hadn't thought of that. That's why I wanted you to come in to do a deep dive, look at the patient. Other times it's like, and I've got a great relationship with the geriatricians I work with. I'll be like, yeah, nah, that's not going to work. Good idea, but and we'll laugh and we'll agree to disagree, and it's fine. But there's a real humour and collegiality in all of this. Um, and continuity of care, you follow patients' journeys over time, you can track their progress. That always makes me happy. You can see people getting better. Or there are times when they're not, and then I decide I'm clearly not the right doctor for them. And I've got terrific reciprocal arrangements set up with other GPs that visit the same aged care facilities. So we proactively suggest that a patient, look, I've tried, I think it's time for you. So one of my best friends is Adam, Dr. Adam Freeman. I say, I think you should see Dr. Adam now. It's time to have just a swap over, and he does vice versa as well. And we seem to find that this often will get that patient and their family to a better place. Sometimes you just need a change in style, and that's incredibly valuable. So that the net impact of this is that you make a tangible difference for the older person, but also their family. Income and benefits. Oh, look, if we just had a minimum guaranteed income, all of us as citizens, and that could pay for the kids and everything, wouldn't that be great? You could just do anything you liked. Well, we live in the society we do. We do need to have money to be able to pay for mortgages, and the kids need jam and the rest of it. So we do need to look at this. So income, of course, varies in experience and location. But I mean, the great boost to aged care in Australia is the enhanced Medicare rebate. So, actually, I'll pause. Catherine, did you want to talk about this now or maybe later on? Is this a good time for you to talk about it? You're on mute, Catherine. Sorry.
Sorry, I was just unmuting myself. Yes, I can talk about it now. So there's a new general practice aged care incentive that has come out, which is part of the Medicare reforms. It came out late last year. So the new incentive is 10 visits to a resident in aged care by their GP provider. The GP does not have to do all 10 visits. Some of the visits can be done by a practice nurse or a nurse practitioner. After the 2 of the 10 visits need to be care planning visits, and the financial incentive is $130 per patient per year for the GP. Sorry, $330 for the GP and $130 per year to the practice. So it's $300 per patient per year to the GP, $130 to the practice. So, obviously you'd have to work out your numbers to see whether it's viable, but there's a number of people, practices doing and GPs doing the aged care incentive who are finding it economically viable currently within our catchment. We've got a fact sheet about the incentive that goes into a bit more detail. So you do have to be registered for My Medicare before you can claim this incentive, but I'll send out the fact sheet and an email with the rest of the resources after the webinar to each of you. Thanks, Jag.
I think, So to say that I work in a group of, we're about 30 of us, GPs. So before the incentive, yes, it was tougher, in terms of trying to do the cost benefit analysis. Now, since the incentive, the reason for doing educate, money is not a reason not to do it, and so we're at least it's about the same, if not better, for the vast majority of us. I think particularly if you're a doctor who does enjoy complexity and typically, spends time and does longer consults, then I think aged care is definitely is likely to be a better bet financially for you compared to clinic, because you have that time and space, and it's just not as stressful because you're not constantly running late. So the money definitely looks after itself. From That's based on my experience with 30 of us, and then you get that quality of life of not being stressed because of people needing time and you having to run late. So here's my typical week. So Monday would be aged care facility visits, and then often say the afternoon, evening might be medication reviews. I might get some residential medication reports. That's fairly typical. Tuesday, um, it might be then this is sort of like a clinic, their home visits, maybe a GP clinic, and then care plan discussions. So you can set those up with the aged care facility, do that via video. And that's an important part of the work we do, reviewing their care plan with the nursing team and providing care plan reports. Wednesday for me is admin, and I do my professional development then. Might do some meetings. Thursday's aged care facility visits, case conferences as well. Those are really enjoyable. So I organise those with the geriatrician after she or he's visited, and then we do that with the nurse in charge, and it's really really useful. Uh, we there have been times when we've invited the family to sit in. But again, just to be cautious. I mean, some people can find that confronting, so I think you just have to think about it. But other times when families, are quite happy to just let us have the discussion, and they sit in. They said that was really useful, and then we can have a chat with the families afterwards. So that might be a way that you choose to do it. And then Friday, home visits, and then weekends. You can choose to be on a roster if you like, but you don't have to do weekend work because so I used to do that, and particularly during COVID, we had a weekend roster. Now we are well provisioned with locum services. The locums tend to cover my weekends. I don't work weekends, but it's just a nice mixed, um, varied week, which I really love and colleagues really love. So, um, how do you become an effective GP in aged care? I'd like to just share some tips and tricks. And what I would say is the most important thing is have really strong processes. So have a definite way of doing things. So things that I do, for example, is I'm really clear with the facility that I will deal with facility work on the day that I attend. Um, because really there might be things that the facility thinks is urgent, but it's not really an emergency. The facility work gets done on the facility day. And when I talk to families, I say, look, I will talk and ring and discuss with you on days that I'm attending because I've physically seen your mum or dad, and then I'll be in a better picture to do this. I never mess up the week, and I'm really clear about having guardrails around what I do. Um, Emails as well. I am clear with facilities about the way to communicate with me. So that, in my case, means it might be an email through to my reception team, and then they will add things to my list for my facility working day. But I'm really clear that I'm not going to be picking up different emails and different things on different days of the week. Um, Initially, maybe the odd facility, I've had some pushback, but then what I've said is the reason I'm doing this is that I'm clear, I'm de-stressed. So when I come and see you, I give you my all. I really then work with you to sort things out and do everything you want me to do. And I think over time, facilities have really grown to appreciate that and understand that this is the way that we're going to be working. Think also about with the nurse colleagues about having structured ways of giving handover. So ISBAR handovers, colleagues will remember from hospital days, but I've reinstituted that with aged care facilities. So we have a structured way of being able to talk to one another to be able to hand over what's happening with our patients. So these efficient workflows give me the time then, the flexibility to not be stressed and to get on with the work, and also a degree of tech savviness. So I talked about embracing AI scribe technology in aged care. That's been transformational because it took time, understandably, to go around and get patient consent, family consent, but not that much time because if you do that over a month, you can gradually see everyone, show them what you're doing, got consent in place. But that means that I can now have a chat with the patient, their family, and the notes are being done by the AI, which just cuts out a lot of that really non-value adding time. And I can give all my time to patient communication and care. And it's made my note checking time a fraction of the time it was before. So that makes me more efficient. And also to have very much a collaborative approach with the team. I think this idea of, if you think you're going, maybe you'll just go in and just sort out the immediate list of things people have come up with. So some Maisie's had a fall, or you go and see Maisie because she's had a fall. The question to really ask is, why has Maisie had a fall? Why does she keep falling? I mean, that's the interesting question, isn't it? I mean, that then is big. That might mean investigations, getting your postural hypertension checks done, trying to find that, having a chat with the physiotherapist. So if you're a doctor who's in that mindset, if you go in and just try and firefight, my suspicion is that you'll find that deeply dissatisfying. And when I've seen doctors who've joined aged care and they leave, often it's because they feel overwhelmed because what they're doing is sorting out the problem in front of them. I think the doctors that really thrive are the ones that are interested. What's going on? Why did this happen in the first place? Let's get together and talk and share our know-how, our scientific know-how. Let's also think about ways to communicate with the patient and their family, and let's put that all together and get a plan that cuts down the risk of falls or behaviors or maybe frequent infections or whatever it is that seems to keep popping up on your issue list. I think that mindset just leads to high quality patient care and deep job satisfaction. So AI's future and beyond. So I've mentioned AI scribe technology revolutionizing note taking, pharmacogenomics. Being able to order tests that tell us which particular maybe psychotropic medications or analgesics is likely to work for this patient. We can order these already. So a couple of the path providers allow us to do that. It's not Medicare bulk billed. It costs about $150 to $200. But sometimes someone who's been struggling, the patient and the family may very well choose to take up that offer and that option, and that can become quite an interesting way of starting to become more targeted. So that's likely to increase, and because of the multiple morbidities we've got in aged care, you, dear colleagues, get to use the full range of your medical abilities because there's loads and loads of stuff in terms of pathology happening in aged care where we can help people. Thinking about enhanced nutrition, interesting stuff happening around that. So working with some facilities that are looking at tailored dietary plans for people to be able to help their general well-being, keeping their muscle mass, reducing any GI side effects. I'm absolutely bowled over by some of the work the OTs and physiotherapists are doing around advanced techniques for maintaining mobility and independence. It's certainly given me some hope from when I become an older person and I am in the position of my patients. And then even smart homes and wearables that start to encroach as well. So just I think making the point that yeah, this is older person's care, but don't you dare for a minute think that this is some backwater in medicine. I don't, no, it's not. I think in many ways it may be at the cutting edge, and there's an opportunity to maybe test out some of these things in aged care in a way that's a controlled environment that would be much harder for you to do for a patient who's at home or who doesn't have the support network around them of the nurses and other staff that you have in an aged care setting. So there's a real innovative angle to aged care, which I think never gets talked about, which surprises me. So, but I want to just dispel any myths that aged care is some sort of backwater. It is not. So I better do a time check. I feel I've been talking for like forever. It's about the right time. Yeah. So pick aged care if you value making incremental improvements in health. So um, I've got a I've got a ship up there. I use this analogy all the time when I'm talking to patients, residents, families, the team, and say, look, um, we're going to make changes, but this is like steering a ship. You make a little change because you know it's going to take a bit of time for that to take effect. So medication changes are typically make a small change and watch for at least a week, if not 2 weeks, then carry on with that and watch and see which way the ship's going. But that's not just my judgment. We have a meeting with the person in the centre to see, right, how's this going? Is this working or not? So if you like making incremental changes, that is deeply satisfying because you continuously improve things and people start to become better. You're interested in medications and trying to really, hone down on medications, use them judiciously. You like leading a team, but I want to put a caveat on that. This is very much not leading where you stride ahead and expect people to follow. No, no, no. It's not that type of leading. It's the type of leading where you're leading, walking alongside the team. You are, it's your demeanor, you're positive, can do, acknowledge that the hurt and the deeply conflicting things that can sometimes happen. You acknowledge that. At the same time, though, there's a can-do attitude. And you maintain a degree of humility where you think, yes, I'm okay. I'm a doctor and I've got value and I know the things I know, but I don't know it all. I'm not the patient. I don't know what they're experiencing. I'm not that person's family. I don't know what they know. I'm not the PC. I'm not the nurse. You see what I mean? You have that mindset where you're listening to each of them. Good conversation actually from the other day where great older person, family, according to the nursing team, is challenging. And I think they are. And we had a good meeting. And what really was evident was the family, every time the nurse, who is wonderful, and started trying to suggest, the family would just cut her off. And actually what helped to really set that aside was when I said, actually, and I'll let me call the nurse Asha. I say, actually, Asha's got a lot of knowledge here, and I'm an experienced doctor of 30 years, but I make sure I listen to Asha. I find it really interesting that you guys don't. Why aren't you listening to Asha? I find it really surprising. I do. I've got 30 years as a doctor. Why do you not let her talk? And so we had a, quite a charged conversation. And they did look and they did smile. I said, yeah. I said, look, can I please suggest, I definitely make sure I listen to you because you know what's going on. And I hope I'm displaying that respect to you. And if I ever don't, you must tell me. At the same time, can I suggest, just as I listen to Arsha, you do too? Can we try that? And let's meet up again and see if this relationship can get better. Do you see what I'm saying? It's that type of leadership that you'll be called on to ask. And Arsha, you can imagine she's really happy. Like, Jag, thanks, you've got my back. Because I couldn't have said that the way that you did, whereas I get to do that. And the family I know is okay with that. And they're okay because they know that I always do respect them. I always do listen to them. So I've bought that respect, which I can now use I can cash that in now to be able to make an intervention to help my team member. So that type of leadership. You should be skilled at having systems set up. So think about, if something keeps cropping up, have a system for it. Think about automating things so that you've got then time to care. And also make sure you have a strong support network because the work it can be emotionally challenging sometimes. So I've got mates who uh, we have a WhatsApp group in our team, and so we have a signal. A signal is need a chat, 5 minutes, need to let off steam. So, and whoever's free will say, "Hey, I'm free," and I can phone that colleague and just rant for 5 minutes, feel a lot better and think, right, I feel like a proper adult now, and I can now think logically, and of course I pay that back, and I'm there for colleagues as well, and that's such a great thing to be able to do, and of course it's possible to do that in the aged care facility as well. And you know what? You've got to like older people, and older people are amazing. I mean, the laughs and the jokes are hysterical. I mean, if I don't come back laughing at something someone has said, it's the wisdom of older people is just hysterical. Um, I got told off the other day. So one of my patients, Mary, is Irish, and she's just come back with, it's looking pre-diabetic. So I'd said to her, I'd said to the team, look, we should probably cut down on the carbs last week. Mary accosts me on Monday, says, Doctor, and I can't do a very good Irish. And she says, Doctor, I'm an Irish woman. You've cut off my potatoes. What have you done? It's like, oh my God, Mary, that's just terrible. You can hear I've got a very English accent. So that's even worse as a born and bred Londoner to have cut off Mary's potatoes. And she was just in hysterics, just making me laugh. You cut off my potatoes. You put those potatoes back. Like, I haven't forgiven you for the famine yet. I want those potatoes back. So it's just things like that are priceless. Absolutely wonderful. So if you can get into that, you will just really enjoy the humor. I mean, I remember the time when um, the facility puts on music for the older people, and usually it's age appropriate. And a few weeks ago, the band came in and decided to put on Karma Chameleon by Boy George. So we had people in their 90s looking around at, really? Really, Boy George, you think this is appropriate? But it's just funny, it's just funny. And that happens all the time. And to have that sense of deep feeling for families, having that sensitivity that people, families are going through a tough time because and I think it's fair to say, people from certain cultural backgrounds in particular. If any of you have Greek or Italian origin, I know you're not going to mind me saying it. I found particularly Greek and Italian origin families, it's really tough. It's like mum has gone into an aged care facility. I don't see that many people of Indian origin, obviously being of Punjabi ethnicity. I can intuit with that. And that's good to be able to have that feeling and think, God, I can see this is even tougher for you because of your wonderful rich cultural heritage. This is confronting, and being able to empathize with that, can mean such a lot. So just to understand, the cultural nuances that are often going on here. But again, don't make assumptions. But maybe having an idea of what might be going on, being able to name it, being able to ask, is this what's going on for you? Having that empathy, being able to feel that pain and helping the families can be wonderfully rewarding. So that's the end goal, isn't it? We have older people, older Australians who the aging process, all right, we can't reverse. We can certainly make life happier. We can certainly contribute to better aging. So thank you very much. And it's time for some Q's and A's. So please uh, type up in the chat function if you've got some questions. I will take us off screen sharing. Oh, by the way, that's my LinkedIn. If you want to connect, just type that into LinkedIn, and it's always nice to connect with colleagues. And I will stop sharing. Great. Kath, did any questions jump up?
There's no questions in the chat. What I suggest is maybe everyone puts themselves off mute. And would you like to ask some questions?
We got a hands up function on. It's
We
been
do.
set up on Zoom.
Kath, I can see there's a couple that have just popped
Oh,
in.
so
some
there is.
questions.
Sorry, yes, there
Just
is.
popped in.
Sorry. Yes, all right. The first one is, are there any skills I should improve or develop formally that's not directly related to medicine for aged care?
Skills. I think the key thing would be, so end of life care is a big part of the job. So my strong advice would be to maybe think about, you could either shadow a GP who works in aged care. I would advise anybody who's interested, maybe think about doing that anyway. I would advise getting to know some of the palliative care meds now. It's a really good question. I will stick it up on the chat, but there's an app I use called Pally Aged meds. So you can actually look, there's an app that will tell you about doses of morphine, doses of hydromorphone. The other people you can talk to build up the next, but don't be worried because you do have support. So you could talk to other experienced GPs who are attending that aged care facility. The wonderful palliative care teams, they're always available. So just I think having that mindset of, look, I'm not sure about this. I need to ask for help. You have plenty of help. Health Pathways, of course, has got loads of resources around this too. So think about maybe end of life care in particular. I think the first couple of times to be able to have a chat with an experienced colleague is probably a good idea because there's going to be a lot of art involved, isn't there, in terms of having the conversation. And then there's the actual science about withdrawing medications and starting to chart appropriate medicine. So that I think would be the big one. Other things such as frequent falls, that tends to be conversations with the physiotherapist to tap into their expertise around, the falls assessment you might do beforehand. The medicines is, pretty vast. Again, you've got support because you'll be requesting residential medication management reviews. So then have conversations with the reviewing pharmacist. That's incredibly useful too. So I think it's more about mindset. The mindset. If you've got the mindset that I don't know it all, I need to ask for help. You're going to be okay. You're going to be okay. People that want proper are people who think I'm going to go in as an expert and know it all, and will then sort of feel very uncomfortable.
Yep, thanks, Jag. We have another question. There must be some difficult conversations GPs need to have with residential aged care home residents and their families. Can you give an example of such a conversation, and how can GPs improve on their skills to have such conversations?
Yeah, no, definitely. Great question. I'm going to divide this up into two types of challenging conversations. So one is a conversation about sadness. Okay, that one actually isn't that challenging. So sadness might be it's the resident, their family, they're deeply sad. You can see that they're anxious. Maybe the family is always on tenterhooks. They keep asking you loads and loads of questions, and you can see what's driving this is care, and they're deeply sad, and they're anxious. They're not quite sure what's going on. They feel a bit disorientated. So I have a staged way of doing this. What I do is I say, let's arrange to meet, and I schedule. It's the long consult. It's a 40-minute consult, and the rule that I have is to start off with, I'm not going to say anything. I would like you just to talk and talk and talk, and I make an absolute rule that I will not talk. That I will just acknowledge and say yes. And if they ask me a question, I said, look, definitely, let me write that down, but I want you to keep talking. And often it can take 20 minutes, and if it's different family members, it's incredibly useful because they get it all out. And often, if you've got different family members, it's the first time they've really heard from one another. So what I do is I facilitate to make sure that each person gets their time to talk and just say what it is that they think. Once that's happened, my rule is, right now we've heard from you, family. Can I ask you now, and is definitely nothing else you can think of? No, nothing else. Can I ask you now just to pause? Now, if you could now please not talk. We're going to hand over to the nursing team now to hear what they think. What do they think is going on? And family, if any of this sounds different, just hold fire on that. We're going to hear from the nursing team, and then the nursing team will talk. Sometimes you get family members that want to interrupt and say, no, look, we agreed, we're going to listen. And because the families had the time to talk, they do. And then by the time we've got to the nursing team, my job as the doctor tends to be to knit that together, what the family said, what the nurses said, what I think. And then you can come to a shared plan. And it's really quite magical. Go from a family who's just not sure what's going on. They get their story out. They can see that we've incorporated their story into what the nursing team wants to do, what I want to do. We get a plan going forwards, and then we document it all, and then share the notes with the family, and we have a concrete plan to work to. So that's my approach for dealing with that type of situation. So think about the diagnosis of SAD. If people are anxious, calling you all the time, just seem to be not quite settled, that's the type of conversation that they need. Yeah. Different type of conversation is angry, which I would say I find challenging. So this is where people are quotes unquote difficult or rude, or it might be the family member who's angry, angry at you, angry at the nursing staff. That, to be honest, I have to manage myself first because often it's a family who's making me angry. And then you know what I do? I post up on my WhatsApp group and I vent that blooming family. I need to kind of get it out of my system and just make sure that I've vented everything that I feel. Then I feel a lot better. And then I'm in the right frame of mind. Say, right, time to schedule a meeting with the family. And then it follows pretty much the same pattern. It is that I have a slightly different demeanor, whereas the sad one, I'm much more caring, and it's like, look, I just want to listen. All right. This one tends to be a bit stricter, which is, look, I understand you've got some anger, and I must listen to you. We are going to listen to you. So what we're going to do is I would like you to say everything that you want. I'm not going to respond to any questions, etc. So if you want details, because sometimes people in those situations will try and throw random. So what is mum's sodium level? Do you even know mum's sodium level? And have you checked her HbA1c? And what was her level 6 weeks ago? And I'm like, I'm not going to answer any of this. I want you to say everything that you want to answer, and then if I need time, I will take that time to go and look at it properly, but I will not be put on the spot. So you can see my demeanor here is much firmer. But because I've vented before, it's firm but respectful, and it's about boundaries. And then once they've said everything they want to say, I say, right, is there anything else you want? Then we get the nursing team involved. Then I say what I think. Then I say, look, this is what I think we should do going forwards. And now this is a question of the most important person here is the patient, then you as the family, the second most important person. But we and me as the doctor have a part to play as well. Now, you have two options. You can work with me and listen to my advice, or if you don't feel you can accept that, then we do need to arrange for a change of GPs. Those are the two options you have. And it flushes out really nicely. So the interesting thing is, having that type of conversation, typically they've got the anger out, and then you can see them warming. And then because I've shown them a little bit of backbone, in a way that's assertive but not aggressive, we're okay. Sometimes though it doesn't work, and they're no, it's still angry and want to change GPs. Now, I've mentioned my mate, Dr. Adam Freeman. What do you think he says? Happens every time. Because I've had the conversation, I've kind of tenderized the situation. So by the time they get to Adam, things are flowing a lot smoother. All right. And the reverse also happens because Adam follows exactly the same pathway that I do. It's an angry family. By the time they've got through Adam through to me, we've managed the situation because the family knows these are doctors who are caring, but they have boundaries. They're not going to be pushovers. They're going to say what's right and what's correct. They will offer their opinion. It's never ever about, no, that was wrong for me to enforce an opinion, but I expect my opinion to be taken into account. And if it's not, then why are you seeing me? Why are we spending time and effort? You need to change GPs. So being very, very clear about boundaries in those situations where people are angry. And over the time, yeah, it's got a lot better now. Hope that helps.
Thank you, Jag. And just to add to that, on the 14th of June, we have the North West Melbourne Primary Health Network is doing a face-to-face session about, so it's for GPs and residential aged care staff. It's on a Saturday, and it's about building the relationship between the RACHs and general practices. And there will be some difficult conversations practice for any attendees. So keep an eye on our website to register for that if you're interested. And also we're holding a session on May the 24th, which is just for practice nurses on advanced care planning. But again, there'll be difficult conversations will be addressed during that session. So again, and again, that's face to face. So keep an eye on our website. So the next question, Jag, is thanks for an interesting presentation. I was wondering how involved you are in the clinical governance of the RACF's, e.g. MAC meetings.
So the MAC meetings, yes, I do attend. I'm just sharing what I found useful is Look, there are meetings. There are meetings. So some facilities run them really well. It's time really well spent. Other meetings, I was finding, guys, you're talking about a lot of things that aren't relevant to me. So what we agreed was we would do the doctor-facing agenda items first because I can be more time effective. So that's why I've been able to do that. I have got involved, so I do enjoy communication, and we'd had a few instances of residents with BPSD, so behaviours and psychological symptoms of dementia. So I'm quite, I find the whole idea of behavioural redirection really interesting. And I just noticed that some of the staff, lovely people, some thoughts about how that might be improved. So we just ran a nice session for the staff. It was really interesting. So getting involved in those types of RACF activities is really, really good. Apart from the MAC meetings, though, I've not really been. I mean, there's opportunities to get involved if I wanted to, but as you probably heard from my demeanour, I tend to be very clear about what I do and what I don't do, about having boundaries. It's just the way that I am, so I tend to be fairly clear with cities. Okay, this I'll get involved with, that I won't. But if you chose to get involved with that, there'd be plenty of opportunities. I'm sure they would jump at the chance. I hope that answers your question.
Thank you. Next question, as I was thinking about things outside of medicine, legal or administrative or yoga, etc.
Interesting. I mean, so if you're getting at maybe a complementary alternative medicine, yeah, it's great. So I, for example, prescribe medicinal cannabis. So I became interested maybe, yeah, probably about 5 years ago, and it was because we'd tried absolutely everything. And then I thought, look, I'm open-minded, and so maybe I should be thinking about offering medicinal cannabis as an option to the patient and the family. So I did, and I've, that's been quite useful. Poor old Adam Freeman's ears will be burning. You can tell we're good friends. His real passion is around nutritional health. So he just thinks that there's a lot here that we could be doing. He's got a PhD in molecular biology, so it's a particular interest. So he has found that, again, it's something that he offers as an option. So it's all about option giving, isn't it? We go through standard medicine first, and then if there are still things that are unresolved, it's another option to offer to families and have a discussion. So yoga, what a great idea. So I haven't personally myself, but I can see how that would fit in. There's a place for it, definitely. You could get involved with a lot of that. Legal and administration, probably two facets. So the aged care facilities will have those teams involved anyway, so I liaise with them. And then from my clinic side, we have that input as well. So that tends to be work, in my case, that is it tends to be done by other members of the team. Again, I hope that answers your question.
Now that's the last of the questions in the chat. Has anybody got any other questions they'd like to put in the chat before we move on?
I've got a question. So I'm just surprised. Why don't more GPs do aged care work? I don't get it. It's like it's flexible. It's really interesting using all your skills. You're using communication skills, using medical skills. You can do, really practice very widely. What's the barrier? I really don't get it. I seriously don't. I'd love to hear from colleagues. Maybe unmute and just tell me. I promise I'll listen. No one's volunteering.
Anyone know the answer to that, or anyone got a theory?
I think young doctors prefer women's health and children's health. Yes, Stephen. That's a fair point. It's because you've got an interest in. Yeah, that's a fair point. It's a fair point.
There is a question in there. How does a GP go about starting to work in RACFs? Do we approach an RACF or do they approach us? I think, Kath, you've got a slide that probably...
We have a slide.
Yes, we do have a slide. And somebody else has also asked, what is the process of accessing RAC work? So it's the same if I'm interested in Northwest Melbourne. So we do have a slide on that. So maybe we'll move on. Unless anyone's got any very last questions. we'll move on.
So,
has that worked?
We can't see you. We can see your
Not sure what's happened.
documents. If you click on your PowerPoint, the icon at the bottom where your PowerPoint's presentation is, at the bottom of your screen. Little orange icon at the bottom of your screen, Kath. Because you're just presenting the wrong things unless you drag your PowerPoint screen across.
That. No.
Should I?
There we go. There it is. Just maximize it. I can see it. Just maximize it now. Oh, here we go. Jags to the rescue.
Great.
So no worries.
Thank you.
Here we go. Not in presentation mode though, Jag, but nearly there.
Oh, right. Okay. Don't worry. You can see that.
Everyone can see it. Not an issue.
Okay. Let's go back. Back there. So QR code and also survey. So that then takes you through to Kath's team. Then Kath, what happens?
So yes, if you contact us if you just indicate on the survey that you'd like to work as a GP in residential aged care, we keep a list of GPs who have capacity to do that, and we should be able to match you up with a residential aged care home that's looking for a new GP. We have constant residential aged care homes advising us they would like extra GPs, and sometimes there's specific. They're looking for specific GPs, so they might be looking for GPs that speak Greek or Italian. Some might request a male GP, some might request a female GP. So all those attributes to include on your survey would be great, and then we can add you to our list.
And that's in the QR code in the previous slide, as well as the next slide.
Yes.
To access that survey. And I will also be putting a link in to the chat. But if you go back to the previous slide, please, Jag. These are resources, Kath.
Yep. So all of these resources then we'll be sending you after the webinar in an email. So the fact sheet that I was talking about before that gives an overview of the GPACI program. There's also the GPACI, there's a couple of toolkits, one by the government and one that was developed by the Primary Health Networks Cooperative. And there's also a toolkit to help build relationships between the residential aged care homes and general practices, which is actually really, really good. And that's just been developed recently, and we'll be working on that to try and build those relationships. And also, as I said before, you'll also be getting the surveys. You'll have another chance to fill that in. And yeah, that's it. So you'll receive that email then within a week. And you'll also get your attendance certificate a couple of weeks later. And your RACGP CPD points will be uploaded in about 30 days. So those will go straight up onto your portal. So as I mentioned before, we've got some more education sessions coming up. So please have a look on our website. And we'll again send you that link with the email that we send the resources. And also, as I said, the session will be recorded, so if you want to share it with colleagues or listen to it again, you're quite welcome to. So that really concludes our session. So thank you very much all for attending.